My name is John Hepburn. I'm Vice President for Research International at the University of British Columbia, and I'm quite thrilled to be here at this celebration of Jim Hogg's many achievements, but specifically the awarding of the Gairdner Wightman Prize Award, I guess it's called. This is actually the second time somebody from our Faculty of Medicine has received this award in the recent past, and we're quite thrilled and hope that next year we'll have another celebration. There are a lot of people who want to speak, and that always happens when you've got somebody who is a builder of an enterprise, a nice guy, and a wildly successful researcher. Many people want to sort of bask in the reflected glory, so Jim's going to have to be patient. His talk will be about 30 seconds long, because by the time he gets to stand up and speak, you know, we'll have already been here for about an hour and a half. So with that warning, I will tell people who are coming, the way this is going to work is I'm going to introduce people who are then going to introduce other people who will then introduce somebody else. Eventually, we'll get to Jim. All right? So I'm going to keep introductions brief. I'm not going to list where people got their degrees, where they were born, where their mothers currently live. I'm just going to tell you who they are, what they do, and they will stand up and roll on. So the first person I need to introduce, and I'm to remind all the speakers but Jim to speak into this thing. Otherwise, you will not be captured for posterity. Your grandchildren won't get to hear you when they see the tape. So, my first person who I want to introduce is a colleague of mine, Bob Sindelar, who very recently became VP Research and Academic Affairs right here at Providence, and before then was Dean of Pharmaceutical Sciences up on the main campus. Bob.
Well, thank you, John, very much. And first of all, good afternoon and welcome to everyone. It's certainly a great pleasure to be here and truly a great honor to be able to represent Providence Healthcare Research Institute and to welcome you on behalf of that organization. It's also great to really say welcome to the family and friends of James Hogg, to those individuals that have been longtime colleagues, for those individuals that learned with him and have done research with him, the individuals that would see him in the hallway, would consider him a friend and a colleague. It's just a great occasion to get together. The heart of excellent research is a quest for understanding that really encourages discovery, encourages creativity, really leads, we hope, to innovation. But great health science research really can translate into recognition for an institution and individuals, but probably most importantly, it actually can end up being something that results in better care and the ability to care better for those people that we do care for. There's no exception today for the recipient of the 2013 Gairdner Wightman Award, and that's Dr. James Hogg, who did exactly that. I asked a number of his colleagues to share with me some of their thoughts, and one of them said this, which I just think is absolutely fantastic. He said, James Hogg's professional journey is all about inspired persistence. His relentless pursuit of truth through science has opened large windows to understanding the lungs in heart and disease. Yet it is the quality of the search, the care for others around him, and the overwhelming humility of his style that inspires others to engage passionately and to amplify learnings so sorely needed by the patients who suffer and their caregivers. Very impressive. We are very lucky to have with us the individual that is the head of the Gairdner Foundation, Dr. John Dirks. And I think John Dirks was going to have an opportunity, if you'd stand first, please. Okay, thank you. And he'll have an opportunity to talk about how Dr. James Hogg really fits the epitome of what his colleagues say. If you think about it, Dr. Hogg has certainly been involved for the last 3 decades in really building a world-renowned center that actually now bears his name at St. Paul's Hospital, very fittingly. He's included in his more than 400 peer-reviewed publications, truly some seminal work that has really redefined the understanding of a disease such as COPD, chronic pulmonary, obstructive pulmonary disease. More importantly, though, his research has transformed the way people look at that disease and the way people treat that disease. He has literally made the difference for thousands and thousands of people. He's had the ability to attract some outstanding young researchers that today are amongst our research stars. He's been able to build a legacy of research that actually has been some of the foundation of what's created the Research Institute that's part of Providence Healthcare, and we owe him quite a bit. But even more important than this, his research has changed the understanding of the disease and has affected people in a very profound way. It's interesting as I was thinking about this, and as silly as the quote is, I think it actually is telling today. The Nobel laureate Linus Pauling said, quote, "Facts are the air of scientists. Without them, you can never fly." Dr. Hogg, no doubt, has flown far, but just as important, his research has helped bring more air in the aid of our patients, and that's pretty spectacular. I now have the pleasure of introducing Mr. Geoff Plant, who is the chair of Providence Healthcare Board of Directors, and Dr. Julio Montaner, who's the director of the BC Center of Excellence for HIV/AIDS, and one of those individuals that have benefited from the mentoring of Dr. Hogg.
Well, thanks very much, Bob. It's really a pleasure to be here this afternoon on behalf of the board of Providence Healthcare. Days like this are days that inspire board members. The work of every single individual who is part of the healthcare community of Providence Healthcare is enormously important. But we're particularly proud when people who are associated with our institution get the kind of recognition that Dr. Hogg has received. When you're a volunteer board member looking at Finance and Audit Committee reports, it's nice to have the chance every once in a while to remember that this is the reason why we do the work we do. It's so that you can do the work you do and Dr. Hogg can enjoy the fruits of a lifetime's effort in delivering better health care. It's also my happy task first to say that if Diane Doyle, the CEO of Providence, could be here, she would. I'm but a substitute. And although I have not planned it, and I made the mistake of testing my own fortitude by running up Burrard Street, I think there's a greeting from her. And so next up, the marvelous CEO of Providence Healthcare, Diane Doyle.
Hey Jen, I'm sorry I can't be there in person to just give you the best wishes and congratulations for this very prestigious award. I happen to be in Ottawa. I am celebrating a milestone of my graduating class from the University of Ottawa School of Nursing. But if I was there, I'd be toasting my wine glass in your honor. So hopefully everyone there is doing that on your behalf. You've done just such a remarkable job over your many decades at St. Paul's Hospital, Providence Healthcare, to bring attention to the COPD and just the impact that it has on world health, and to bring the evidence to bear that has made such a significant impact on improving diagnosis and treatment has been remarkable. But I think what I really want to commend you for is the ability that you have brought to train and influence so many others who have added to that world knowledge and continue to add to it. I have this sense that great attracts great, and so you have been just a great magnet for attracting wonderful researchers and clinicians to the organization. And so I thank you for that. I thank you on behalf of the patients whose lives have been improved, and I thank you on behalf of our community for the reputation that you continue to build on our behalf. Have a great evening.
I'm Julio Montaner. I'm the director of the BC Center for Excellence in HIV/AIDS. It'd be my pleasure to tell Diane that Geoff didn't bring the wine, so we're toasting with nothing. Thank you, Geoff. I won't take too much of your time. Suffice to say that I'm here to represent all of us, all of those that have had the privilege of training at the gym. Jim somehow picked me up at a conference. I don't know exactly how, whether I pick you, you pick me, but at the end of the day, He got stuck with me back in 1979. And in 81, he gave me the opportunity to come to Vancouver and start what I thought it was going to be a career in respiratory medicine. And look at what happened then. Anyways, I'm grateful for your teachings, for your mentoring, for your inspiration. And I'm speaking on behalf of a large number of people, many of them here, who I share the privilege to train under you. And when we heard of this award and this ceremony, we thought that we wanted to give you a small little present. If you don't mind just joining me, this is a painting that we feel is very special. It's a reproduction of a St. Paul's Hospital image that Tico Kerr, a patient of ours, came up with in thanks for all of the hard work that St. Paul's did for him, and we thought it would be a great tribute for you. So that's our present.
Thank you very much.
Thank
I really
you.
will appreciate it. We'll keep it here for you.
It's now my great pleasure to introduce Dr. John Dirks. John is come in from Toronto, where he is the president of the Gairdner Foundation, and he has been with the Gairdner Foundation for a number of years and used to be in charge of the Medical Advisory Council. John.
Thank you, John. It's always a pleasure to be back in Vancouver and St. Paul's Hospital in UBC, where I spent many happy and interesting hours. And it's great to come on this special occasion when we're honoring Jim Hogg. Now, the Gairdner Foundation also has here seats Lauren Terrell, who's the chairman of our board of directors, who just came in from Edmonton. And happily, Dr. Lapchi Choi, president of the University of Hong Kong, is here, who in 1988 won an international award for the identification of the cystic fibrosis gene along with his colleagues. So Gairdner has its ambience in this room. The Gairdner Foundation has 3 awards: International Award, the Global Health Award, but one that receives perhaps the highest profile is the Canada Gairdner Wightman Award. And Jim has been chosen by an international advisory group that looked over everything. The Gairdner Wightman Award is given for someone who's had a long, sustained career in science and topped up with major leadership of the highest quality. And Jim qualifies on all counts. We all know his research, what he has done in chronic obstructive lung disease in delineating the pathophysiological disorder along with other colleagues. And he's pursued this for 40 years. His work on asthma, lung transplantation. So it's a marvelous career in research has been iterated already. And then he's been a major leader, and it beginning right here. And I gather, and David Harwick, we worked together on this. Remember the recruitment of Jim Hogg and Peter Perry. My first encounter with this was in 1976, I should say, when Bill Herbert, who was the excellent physician-chief in this hospital, said, as I was being recruited, we need to have research here. And I said, what do you like? He says, lung. It was as simple as all that. And I said, have you got space? He says, we are about to empty a ladies' locker room. And so it happened. But it also shows you the passion and the drive that Jim Hogg has to do research. He always tells me every time I meet him somewhere, he says, you know, I loved being director and being at all those board meetings and out to the university campus, but I really like to do experiments. Experiments that long-term will solve some of the questions, will answer some of the questions that I've had buzzing in my brain for many years. And that's what he likes doing best, and that's what he does best, and that's what he's doing here today. So he built here at St. Paul's, at UBC in Vancouver in British Columbia, but also on a national scale and on the international scale. I think that Jim, when it comes to pathology alone, is the lung pathologist, that if you got a diagnosis that you don't know, send it to Hogg. When you want to have connections with those who are doing work elsewhere. He's such a superb collaborator. So what better choice could be? And as John Hepburn mentioned, he joins an excellent group of recent Canada Gairdner Wightman winners, such as your own Michael Hayden, now in far-flung country. Jim will be honored on October 24th in Toronto at a celebratory dinner. I hope UBC has 2 tables along with St. Paul's, so sign up. But also, he will be part of the requirements, as it were, responsibilities of a Gairdner winner is to make a contribution to science education in Canada. And Jim is particularly welcome, and he'll be working for us in 6 places, and it's like, and a couple more in the winter. But he has a message that everybody wants to hear. After all, COPD, I think, is the 4th major cause of mortality in the world. So Jim's going to do this, and we'll be happily honoring him. He gets a check of $100,000, which I think for Jim is just small change. But I want to say that from the perspective of the Gairdner Foundation, a long-term observer of his great contributions to pulmonary disease and to Canada and the world, and as a friend, I can't think of anybody better than to have Jim Hogg as the Canada Gairdner Wightman Award winner for 2013. Congratulations.
And now, Gavin Stewart, the Dean of Medicine, is going to heap praises on behalf of all of Jim's many colleagues at UBC.
Thanks very much, Jim, and thank you, John, and I'll be very brief. And Jim, just wanted to offer my own personal congratulations, and that on behalf of the Faculty of Medicine at UBC for all of your accomplishments, but certainly on this particular recognition. I also wanted to say thank you. And I suspect many persons in this room are aware of it, but I think it is entirely appropriate to point out the impact that you've had on the British Columbia environment. And my understanding is that at the time of your recruitment in 1977, the then Dean, Bill Weber, a wonderful person, and the head of the Department of Pathology at that point, David Hardwick, another wonderful person, had collaborated in attracting you to St. Paul's as one of the sort of coveted pathologists in Canada and internationally at that point in time. And that was at a time when in this environment there was a thriving culture of research and teaching at the Vancouver General Hospital, but it was essential that that same culture be built and enhanced within the environment of St. Paul's Hospital and now Providence Healthcare. And your recruitment and your excellence in teaching and research is what has really spawned a culture of research and excellence in St. Paul's Hospital, within Providence Healthcare as an academic medical center. And for that, I think we're all very grateful. And I think the trajectory that has occurred within the Vancouver environment and elsewhere in BC now that has followed your accomplishments in that regard has allowed the development of other academic medical centers like BC Children's Hospital, like BC Women's Hospital. But that was a seminal moment in the development of academic health in British Columbia and Vancouver. And I'm most grateful to you for being the key component of that. I would also just like to note that certainly I'm acutely aware of the impact of role modeling on our learners, our fellow scientists, colleagues, and others. And your humility in the face of excellence, I think, has been incredibly powerful in terms of providing that role model to our learners, to our junior colleagues. And it's, as I have been told, it's never about Jim. It's about everybody else and how do we support them. And that's an unusual trait and certainly a very powerful one. And again, most grateful. So thank you very much and congratulations.
And now we're closing in on the main event. And I would like to add, obviously, my congratulations, but also if we could clone people like Jim, it would be spectacular. To be a great researcher, a nice guy, and truly a leader and a builder is really, really a rare combination, and we treasure it. So, longtime colleague of Jim, we've already heard Dr. Peter Perret was recruited to UBC and has worked with Jim for many years, and I think he has something to say about Jim.
Thanks, John. Well, it's a great privilege to be the penultimate person to introduce Jim. And I think I'm in a position to speak about Jim because he's been my mentor, my colleague, and my friend. Actually, as I look around the room, most people here have been either mentored, colleagues of, or friends of Jim. And as Michael Ard was saying, if you did a nodal diagram of everybody in the room, they'd all be connected by some line to Jim in a complex network. It shows how impactful you've been. But I thought I would just give you a little bit of, I can switch here, Jennifer. Jim's formula for the Gairdner Award. So how do you go about achieving this? Well, there was a very unlikely starting point, and that was in Sioux Lookout, Ontario, which is the hub of the North. Now, most of you probably don't know where Sioux Lookout is, so I got a Google map for you, and there it is. There's Thunder Bay, there's Winnipeg, so somewhere between Thunder Bay and Winnipeg, not even on the Trans-Canada Highway. There's a maximum of 5,000 people live there, and the reason it's called Sioux Lookout is not because the Sioux looked out, but the Ojibwe. And that they were looking for the Sioux who were coming to take their women and children. So there's a mountain there from which you can actually see the river and see the birch bark canoes of the Sioux approaching. So they were able to allow the women and children to escape. But the Sioux Lookout's not that famous. It is famous for some things like very large pike, very large moose, and very large forest fires, but not for science. In fact, when Jim was growing up in Sioux Lookout, his aspiration was to play for the Flin Flon Bombers, which is a hockey team from northern Manitoba, even further north than Sioux Lookout, and that was his aim. And when he was 15, his coach told him, "You're not going to make it." And that's when he started to take studies seriously, and that changed the direction of his life. And for the best, because now Sioux Lookout will be famous for having a Gairdner Award winner. So now, this is his siblings. That's Jim there, and his two brothers, Rod and Ross and Alice. And when Jim was fairly young, his father died, and his mother had to raise these 4 children. And you can see that the budget for clothes was not big. So it was rough times then. And that and the rejection from the Flin Flon Bombers engendered in Jim one of the characteristics to win the Gairdner, which is a steely resolve. This is Jim when he was in the Air Force, because he went to medical school at the University of Manitoba, but to get through medical school, he had to join the Air Force and pay them back for 3 years after medical school so that he could get through school. So I think you can appreciate the steely resolve there, and I think our skies were safe when he was with the Air Force, don't you think? So, steely resolve. The other thing that you need to get the Gairdner is mentors, and Jim had his mentors. Even before he went into the Air Force at the University of Manitoba, he was influenced by this man, Joe Dope, who was a very unique individual, professor of physiology, who ran a program for medical students to do research and influenced a whole generation of clinical investigators in this country. And Jim's not the only one in this room who was influenced by him. John Dirks was, and many others, Henry Friesen. And while he was in medical school, he got interested in the lung because of his exposure to Reuben Cherniak. And thank goodness he met Reuben, so we have him in lung disease. Then after the Air Force, actually while he was still in the Air Force, he went to work with Charlie Bryan in Toronto, and actually he was spun in a large centrifuge, I think, to see what effect of gravity had on the lung. And while there, Charlie suggested he come to Montreal to do a PhD with Peter Macklem. And Peter Macklem was probably his most influential mentor. And then at McGill, he was also mentored by Whitey Thurlbeck, which a pathologist who gave him the interest in pulmonary pathology. So mentors are a really important ingredient. And of course, Jim has turned that around by mentoring us. So the other thing you need is champions. And Jim has had champions over the years. David Bates was the dean before Bill Weber at UBC. And I think it's really this triumvirate that had the idea of recruiting Jim Hogg to UBC. They plotted together for some years before. So John and David were important champions. And then even Bruce McManus, a cardiovascular pathologist, has since been an important champion of Jim. Now, the other thing that Jim has in spades is an adventurous spirit. And as you heard from John Dirks, when Jim came here in '77, he was leaving. He was a professor of pathology already at McGill, and he was leaving one of the most prestigious pulmonary labs in North America to come to a nurse's locker room, really. It was not even renovated by the time we came here. Now, I was just a young fellow, and Lisa Bale, who came with us, was a just recently completed master's student who we were in it for the adventure. We were coming here because Jim was a great guy to work with. We were just at the beginning of our career, but Jim was taking a big risk, right? And so that shows his adventurous spirit to start something new from scratch. So that's been important, and he's done that over and over again, right? Take a risk, do something new. Now, he took a risk, but there was lots of potential support. And the support here came from the province of British Columbia. David Hardwick managed to get some money out of the government, which is a hard thing to do, to support the lab. And here is the Minister of Advanced Education, Pat McGeer, at the opening of the Pulmonary Research Lab in 1977. But we also had support from University of British Columbia, and there's that face again. That face keeps coming up. David Hardwick was the head of the pathology and got support from the university. And we got money from the hospital, the then CEO and chairman of the board. And we got money from the BC Lung Association. So you need not only adventurous spirit, you need support. And this was almost unprecedented in my experience to have all these groups come together to collaborate on a major recruitment like Jim Hogg. So the other thing you need, of course, is encyclopedic knowledge. And Jim is always reading. He's always quoting the latest Science or Nature article to you. So he's an exemplar of research is a lifetime of learning. Sometimes he takes this to extremes. Here he is reading about the basics of the circulation while his research subject is about to be experimented on. And luckily, Julio can't see that Jim is just brushing up on his pulmonary anatomy before the experiment starts. So the other thing you need is trainees. And Jim has had generations of trainees. And I say generations because he's actually had trainees who are the offspring of trainees, right? And here is a particularly productive group, as you can see. A small sample of an enormous cohort of people who have been influenced by Jim over the years. So trainees are really important. And excellent, loyal staff. and their loyalty is because of Jim. So I can't name them all. Some of them are here, some of them are gone, but just a few. Wendy Cunningham, Joan Dixon, Dean English, Diane Minchell, Stuart Green, Mark Elliott. Sorry, Mark, you got your tongue out there, but Ray Dalby, Barry Wiggs, Fanny Chu, and many, many others. And they were loyal and they were excellent because they were well led by Jim, and he gave them some degree of freedom to run the lab. He had a brilliant idea to form the MOM, the McDonald Operations Management Committee, and on that were faces you've seen, and also Joe Como and Janet McManus, and they were the group who allowed the lab to run so Jim could meet with the trainees and dream up his wild and crazy experiments. So the other thing you need is supportive family. And here Karen Hogg and Bob Hogg have always been supportive of him. And most recently, Juan Tan is not only family, but a colleague in science. So some more of the ingredients. Then you need a sense of humor. And you've heard about his humility. He's also got a great sense of humor, and he's often laughing at himself, so, which is an important characteristic to have. But the most important is an insatiable curiosity and perseverance. And he has that in spades. And that is illustrated in his 5 seminal New England Journal of Medicine articles. So when he was doing his PhD, he did what was pretty revolutionary at the time, these amazing bronchograms of the tracheobronchial tree in patients with emphysema, and he measured the resistance of these small airways. And he found, with Peter Macklem, that the resistance was many times increased. And he's been trying to figure that out ever since, right? 40 years he's been trying to figure out the mechanism of that increase in airway resistance using progressively more sophisticated technology. So that resulted in his first New England Journal of Medicine paper in 1968, The Site and Nature of Airway Obstruction. And then he went on to look at age as a factor in that peripheral airway obstruction. He looked at the structural changes in those small peripheral airways. And then recently he looked at the nature of small airway obstruction in chronic obstructive pulmonary disease. At 2004. If that title sounds a little reminiscent, it's because it's almost the same as the 1968 article. The site and nature, the nature. So, and that's not an accident. He designed it that way because he realized he was still asking the same question, but in a more sophisticated way. And then this is his latest New England Journal paper in 2011, with John McDonough, a graduate student, where I think he's finally answered the question, which is why the airways resistance is increased. And this is in a normal subject, as you go from the trachea out to the very smallest airways, the cross-sectional area gets bigger and bigger and bigger as you get more and more and more airways. And when you get out to about the 14th generation, you should have a large cross-sectional area. But what John and Jim found using micro-CT was that in patients with COPD, there's a substantial reduction in cross-sectional area due to a loss of airways. 90% of the airways have been obliterated, disappeared. So that quest has been going on for 40 years, and you think he'd rest, right? But no, he's at it still. And this is just some courtesy of Dragos Vasilescu, one of his recent fellows, or his existing fellow now, just some images. He's doing micro-CT on these little bits of lung, and this is an image I don't even think you've seen, Jim, that I have to use my mouse. Let's see if the animation works. So this is this is a CT image. That's not microscopy, going through a whole, and that's a 3D reconstruction of a portion of the lung and the peripheral airways and emphysematous spaces. So Jim's still at it, still pushing the frontier, and still trying to answer the question of what's wrong with the lungs of patients with COPD. And he's made fundamental contributions to our understanding, which is having important implications for how we're going to prevent and treat this important disease. Now, I'm not the last speaker, but I get to introduce the last speaker, and that is Bob Hogg. And Bob is a substantial researcher in his own right. He is a professor at Simon Fraser in the Faculty of Health Sciences, and he's published more than 400 peer-reviewed papers. And Jim, I know you're not competitive, but if you were competitive, you better look over your shoulder because he's closing fast. And he's making fundamental contributions in another important disease, HIV/AIDS. So, Bob, the last word goes to you, the man as a father.
So thank you, Peter. I'm not here to talk about my research or the work that I do. I'm just here to really congratulate my father, and I'd like to take this opportunity to acknowledge my other family members that are here as well, Juan, Sam, and Karen. There's a number of us that can't make it. Carrie's on her way. She's teaching. Aaron's at a swim meet. The younger kids you don't want here, so... But we all have a message just to say thank you for your hard work and congratulations on this honor. You really deserve it. So come up and give your talk.
Well, first of all, I'd like to thank everyone who's spoken before me for all of the very generous remarks. And I'd obviously like to thank the Gairdner Foundation for this award, and it's a lifetime award, and it really represents a team effort. And I think that you've seen something of the team, and I accept the award really as part of that team effort. Now, what I'd like to talk to you today is about some new experiments that we're trying to do. And the greatest thing about science is if you've been working on something for as long as I have and you haven't got the answer, then there's got to be something wrong. And the greatest thing that's happened is the increase in technology. I think that the ideas don't really change that much from year to year. But I think the technology, especially in current times, is changing at a terrifically rapid rate. And before I move on to these experiments, this is the beautiful city we live in, which everyone recognizes. And I'd like to thank the audience, because I'm fully aware that this is Friday afternoon, and it's a beautiful, beautiful mid-spring weekend starting, and that most of us would like to be somewhere else and heading toward our summer places and where we spend the weekend. And I'd like to thank you especially for coming and sharing this with me. I'd also like to thank the members of the Gairdner Foundation, the board, that have come, and particularly Lapchi Choi. It's a real treat to see him here. And thank especially the members of the university and the members of the hospital and that whole environment that has provided really a wonderful place to work for me for the last 35 years. And it's been a great run, and I hope it'll last just a little bit longer. Now, what I'd like to talk to you about is some work that we're doing as a collaborative work with a number of people around the world, and I'll mention them as we go along, but we're trying to use what we've learned so far to start to look for new molecules that might be of benefit. Now, just because we have a mixed audience, I'd like to talk a little bit about breathing. And this is a flow volume diagram that I'm going to show you. And the volume along this axis and the flow along this axis defines what the respiratory system can do. Now, you're all sitting there, and you have just taken a breath in that might look like that, and a breath out that looks like that, and you do that a certain number of times every minute, and you can't stop. You have to do it. You do it unconsciously, and if you stop, there's real trouble. Now, if someone asked you to take in the biggest breath that you could possibly take, so it took you to the top of your lungs, that's what it would look like. And then if they asked you to blow that out just as hard and as fast as you could, that's what it would look like. And that provides the envelope with which you can breathe. And this is virtually your signature, that you can try as hard as you like to get beyond that, but you can't. It's because the way the lung is designed. And as one of the things that you can do is you can get about 80% of your lung volume out in the first second. Most of you can do that. And the full lung volume, which is called the vital capacity, is what you can blow out if you blow out as hard and as fast as you possibly can with some hard-nosed pulmonary technician shouting at you to expire, expire, expire. And that's what happens. Now, how do you make a diagnosis of COPD? Well, it's based on this diagram, and it's related to the FEV1, that number that we talked about, and the vital capacity. And if we look at this picture of the peripheral part of the lung, the chronic obstructive pulmonary disease is diagnosed when you measure the maximum volume of air that's going to be forcibly expired from the lung in 1 second, what we've been talking about. And when you compare that to the vital capacity, and under normal circumstances, this ratio is about 80%. And then as this declines, it does so because there's obstruction in the small airways, and because there's emphysematous destruction of the alveolar tissue at the distal part of this airway, which you can't really destroy. And that is the resistance and the compliance. Resistance and capacitance, if you like electronic analogs, and the unit of that is time. So the longer the time gets for you to blow out, the closer that you come to your maximum breathing capacity. And if you sit there as you develop this disease, the first thing that happens is you can't empty your lungs properly. So the only thing you can do is move up that diagram and breathe at a higher lung volume. And if you want to feel what a patient with COPD or in an asthma attack feels, just go up to the top of your lungs and breathe there for a few minutes. And I think you'll find it rapidly becomes very uncomfortable. Whoops. Yeah, I'll just keep going. Now, this is a famous diagram by Fletcher and his associates, some workers in London who studied London postal workers, and they followed them over a long period of time. This is, nothing gets as good as it was when you were 25. So if you plot your FEV1 at age 25 and everything else as a percentage of that, most people, their FEV1 declines with time, but not very much. If you smoke, the majority of people won't get any worse than this. And if you stop smoking, you'll get better. This is over 75% of the people. Then there is this susceptible minority that crash like this. And to be honest, we don't know why they crash. We would love to know. But they often haven't smoked any more than the people who are up in this group. So we know it's more than just the smoking. Now, the work that I'm going to tell you about as we move along is contributed to very much by a very courageous group of patients who've got this very severe disease. And the only answer for them is a lung transplant. And after they've agreed to a lung transplant, they're approached by someone. We obviously can't do it, but through the ethics committees and the approval of the ethics committee, they're approached to ask if they will donate the lung that is going to come out of them to us for research when they get their new lung. So the work that I'm going to tell you about now is all based on those sorts of patients. And what we'd really like to do is have something that we could prevent or reverse this rapid decline in FEV1. We don't have anything that will do that at the present time. Stopping smoking helps a little, but if you're one of these people who are going to crash, and many of them have never smoked cigarettes around the world, perhaps one of the biggest things is the smoke that women are exposed to while cooking, and also other sorts of air pollution that produce this disease. And the other thing that we'd really like to be able to do but can't is shown here. Maybe I can use this thing before. Shown here is to be able to identify the people who are going to crash while they're still up here. Because if we knew who those 25% or 20 to 25% were before they started to crash, maybe there's something we could do about it. Now, this is a recent article from two German investigators, and it's really an editorial that was written about some work that we did about the generation of personalized drug discovery. And in that piece of work, they said, first of all, you had to recognize the disease. Then you had to be able to define and quantify its histopathology to understand it, how it is under the microscope. And then look at the gene expression signature that's associated with those microscopic changes. And then used an unbiased drug screening approach, which is called the connectivity map. It's a bioinformatics tool, and I'll speak a little bit more about that later, but not too much detail. And what that bioinformatics tool allows you to do is to feed the gene expression signature that you have defined into it. And it is a compendium of sort of everything that's been done by experimentalists on treating cells with drugs or tissues with drugs. And it will define and provide you with a drug that might reverse the signature that you have. And under those circumstances, you have generated a hypothesis about a molecule. You haven't proven anything, but you have to move on to the next stage. So in our case, we have COPD quite well defined. I'm going to tell you about how we measure the regional severity of the emphysema and how we compare that to the gene expression signature for the emphysematous destruction, and then how we have identified a tripeptide that might serve some of these things. It's not something to get huge hopes about, but we've made that first step as to generate a hypothesis, and we're beginning to do the studies that hopefully will allow this thing to be moved on into a potential novel therapy for this condition. Now, this is a lung that's been donated for research by a person who's had a lung transplant. And as soon as it's taken out of the patient, it's immediately put in a semi-sterile environment on ice to keep it cool. And then it's kept cool till we bring it to the laboratory and we inflate it with air and we rapidly freeze the whole lung by surrounding it with liquid nitrogen, vapor. And this is the lung, frozen solid. It's actually sitting on a piece of dry ice, and the photographer has kindly made that nice black background for us. And then we cut the lung up, we keep it frozen. Well, first we do a CT scan on the whole specimen. So we have a CT scan of the whole specimen. And then the lung is cut into slices like this so that we can position these slices on the CT scan and that we can also begin to study them. And we take this middle piece here, slightly smaller, that piece, and we put it into a fixative that we can cool down to -80 degrees and freeze it and dry it. And then we can look at that thing with micro-CT, the sort of experiments that Peter showed before. And this particular experiment was done by John McDonough. And this is a terminal bronchiole, which is the last conducting airway that's breaking into a respiratory bronchiole. And if you got that on histology, you'd be stuck with it. Whoops. Now, what you can do with that sample is to match it up with the histology that's formed on another sample here. And then by processing that sample, which is frozen in a special way, we can do the histology and also cut side-by-side sections for gene expression studies. So we can do gene expression profiling on this piece of tissue and do the measurements of the terminal bronchioles and respiratory tissue on this piece of tissue. And we can bring those two things together. So we can establish the gene expression signature by direct comparison of micro-CT to histology. And in this work, we've collaborated with a group from Boston University by the name of Avi Spira, who's a remarkable bioinformatician and also a chest physician. Now, the beauty of this thing is that you can take this sort of thing and use the benefit of the software to put that exactly into the XY plane. and you can see that terminal bronchiole. Now you can see the alveoli opening off it, and you can look at that in cross-section and measure it very accurately. And what we found was shown here. This is the controls. I'll explain these other terms in a minute, but this is the central-lobular form of emphysema, and this is the panlobular form of emphysema that comes in people that have a specific genetic defect. And you can find that there's a drop here, a tremendous drop from the control levels to about 10% of those control levels in the end stage of these diseases. So that we learned something here, that the disease really starts in the terminal bronchioles, and with alpha-1 antitrypsin disease isn't quite so bad. Now this is an example of the central lobular form of emphysema, and I think you can see there are normal areas of this lung, and there are mildly diseased and very severely diseased areas of this lung. So by taking this approach and taking samples from the top to the bottom of the lung, we can look at the progression of the tissue destruction on the same genetic background. And that's an enormous advantage for us. And here is the panlobular form of emphysema, and I appreciate that this upper lobe here is really quite normal looking, where you get this very lacy destructive pattern throughout the lower lobe. It's never as severe destruction as you see here, but this is the form of emphysema. We don't know why these two things are that different, but we're trying to find out. Now, if we take the measurements across, starting at the top of the lung to the bottom, you can see in the controls they're pretty uniform, and this is the frequency distribution of that. And that the control lungs, they have alveolar dimensions range between about 225 here, all the way up to 600, with a 95% confidence interval of 489. So what that allows you to do, this is the frequency distribution of the controls, and these are our two types of emphysema, and we can take these regions of the lung where there's no emphysema at all. And from those, you can count the number of the terminal bronchioles, and you can see that they're mostly lost before any emphysema develops. Now, we're involved in some experiments now with Dragos Vasilescu and Tilly Hackett, who are looking at some specimens that we have from, it's very hard to get people with very early disease to get their lungs, but we have specimens from patients who have had lung cancer that we've measured their lung function, and you can get the early disease, and they're in the process of asking the question whether you start to lose those airways at a very early stage of the disease, and certainly you have. So the next step is to quantify this, and here we owe a lot to the geologists. We take the same process as geologists use to find out how much ore there is in rocks. So if you want to know how much ore there is in a rock, how much gold there is, they break the rock up into little pieces, and they look at the area fraction of the ore from a random sample of their rock, and then they multiply that area fraction by the total volume of the rock, and they get the volume of the ore. We do the same thing. We use the CT scan here to get the volume of this lung, and we can measure the tissue volume of the lung, and then we use the whole lung samples here to get the volume fraction of all of this tissue that is taken up by the airways. And if we multiply 1 by the tissue volume here, we get the volume of the small airway tissue. And then we can take to the next levels of magnification and find all these cells. And here's the data for bronchiolar tissue. This is the normal volume here in the control cases. And starting from the bottom here, this is the inflammatory cells. This is the elastin. This is the collagen 1, the collagen 3, the other forms of, or the collagen 1, the collagen 3, and other forms of tissue in the control lung. And here you can see before, while you're still in the emphysematous range, the airways have got, airway tissue has increased a little bit in volume, which accounts for the early thickening. And you've begun to see a tremendous reorganization of the collagen and loss of elastin. And by the time you can get to the level where a radiologist can see the emphysema on the CT scan, you can see the elastin is destroyed, and there's been a remarkable reorganization of the collagen tissue. And this was really scar formation. Now, if you like pictures rather than graphs, this is a normal airway. This is an airway which we really didn't understand in our early stages. It was a little thinner than normal. Now we recognize that these are airways that are probably waving goodbye. it seems to be a pretty bland process. This is a mucus plug, and these cells are largely epithelial cells. There's not much in the way of inflammation. But we also find airways that look like this, where the airway walls are tremendously thickened by an extremely active inflammatory process, all those black dots, and that this plug is actively inflamed with lots of cells in it compared to this one. And they finally end up as a fibrous-scarred airways. And these are the ones who have survived. Many of them haven't survived. So if we look back at this picture that we saw before, we sort of defined the pathology as we wanted to do in those various categories. And we can do this now in the patients. We've done this in patients that are compared at different stages of the disease and in looking at different regions of the same lungs in people that have donated their lungs after they got down to this stage of the disease. And this is the gene expression signature. This work was done by Avi Spira, our collaborator at Boston University. And this is 127 gene expression signature for emphysema. This is a low LM, the normal part of the lung, no emphysema. This is severe emphysema. And you can see there's a group of genes that are red here that have increased their expression. And there's a group of genes here that are green, and they've decreased their expression as the emphysema gets worse. And this 127 gene signature is associated with progressive emphysema, and that the genes that increase their expression are enriched for genes in the inflammatory immune cell signaling pathways that contain many of the genes that are in the inflammatory cells that we've measured going into these airways. And the genes that decrease their expression are enriched for genes that are associated with tissue repair, and they include genes that you'd see late in the disease in the scar formation, and we think that happens in the airways in the late stages of the disease. Now, this connectivity map is what we've shown. It's freeware on the internet if you're smart enough to use it, which I am not. But the people that they work with are able to feed this gene expression signature into this connectivity map. And when they did that, out came a tripeptide, Ghk, as a possibility for a drug that could potentially reverse this proposal. And then with the help of Tilly Hackett and others in the laboratory who had access to fibroblasts that had been isolated from lungs with patients who had COPD and expressed this abnormal signature, she was able to treat those both with TGF-beta, which we knew was shifted down, and also with GHK, and was able to restore that thing. And we're in the process of doing the animal experiments now that will show whether this will be able to reverse emphysema in a model of tobacco smoking. So what is GHK? It's a tripeptide that circulates in the human plasma. It's complex to copper, as GHK copper, and it's bound to a plasma protein, and it's in concentrations in our blood at about 200 nanograms per mil when you're 20 years of age, and that falls to about 80 nanograms per mil when you're 60 years of age. Synthetic GHK is currently an ingredient in reparative and anti-aging cosmetic creams based on the evidence that it can activate wound healing, it can attract immune cells into the damaged tissue, and it can promote antioxidant and anti-inflammatory effects and stimulate collagen and glycosaminoglycan synthesis in skin fibroblasts. And Tilly Hackett will be doing these studies over again. So if we come back to our diagram, we've defined the disease, COPD. We've found a way to measure the regional severity of the emphysematous destruction. We've looked at the gene expression signature that's associated with that, and we've identified this tripeptide, and we've done some in vitro validation of the GHK, of which we have to do a lot more, and then hopefully we'll have a molecule that will go beyond to the clinical studies. Now, there's been a lot of collaboration around with this, and oops, I went back. And these are the people that have collaborated with us. Starting with Bob Rogers from Pittsburgh. He's the late Bob Rogers now, but he did a sabbatical year a few years ago, and Harvey Coxon was a PhD student at the time, and Bob and Harvey did an awful lot of the early work with the CT scans. And then Joel Cooper, a very old friend of mine, who's a surgeon in St. Louis. He never would claim to have invented the lung transplant, but he's certainly the person that made it work at the University of Toronto. And he moved off to St. Louis and is now at Philadelphia, and we still get many of our lungs from Dr. Cooper and his associates in that. And then Boston University, who I mentioned, there's Avi Spira. Julie Zeskind and Josh Campbell are two PhD students who did a lot of the bioinformatics work, or all of the bioinformatics work on these two projects. Both of them, it got them their PhDs. And Julie, when I first met her, I thought she was maybe a high school graduate or an early college student. It looked like a good puff of wind would blow her away. She actually had a master's degree in bioinformatics from MIT at that time. And while in her PhD, she had an uncanny ability to keep focused. Because while doing these experiments and getting her PhD and writing her paper, she also managed to have 3 children, 1 per year for each year of her PhD. And Josh Campbell, who was her colleague, and really did a lot of the work with the connectivity map and also got his PhD. His wife produced twins during the course of this, so that's productivity that's hard to match, as well as the scientific work that they did. And then names that have already been mentioned, like John McDonough, a PhD student who's now over in London, Masa Suzuki, who's at a postdoc who's gone back to Japan, Ren Yuan, Tilly Hackett, who's joined our staff, Mark Zay, who's a PhD student at the moment, Dragas, whose name has been mentioned, and Daisuke Kanose, who's doing a lot of the laser capture work, and many others of my long-term colleagues. And particularly, I'd like to thank Peter Parry. As has been mentioned, we came out here many years ago. We meet every Tuesday at 1 o'clock to discuss data. And sometimes those discussions get pretty heated. But it's nothing but a spirited discussion of the data. But we have had students who have not complained to us directly, but have complained through other people that they don't like to see us fighting all the time. But it hasn't meant very much. I believe he's my severest critic, and I thank him for that. Because if you want to make progress in science, you have to be ruthless with the data. And I think that he's done that very well. And with the financial support here of a number of agencies, I'd like to particularly thank the NIH, who supported me very well over the since I officially retired in 2000. I've been really very thankful for the support that I got from them, also from the CIHR, the BC Lung, and we've got some support from industry, particularly from GSK and Merck, and I'd like to thank them for that. And for all the people in the room who've worked with us here at St. Paul's, it's from my perspective, it's been a great ride, and I hope it goes for just a little while longer. Thank you very much.